It's lovely to have everybody here. Love it. New friends. And again, we don't always do this, but if I think we should probably do a better job. So Gravity has a listserv for each of the different actually probably Sarah, you probably already do this. I'm just forgetting. Like there's a way to you can come to our meetings like independently, or you can register as someone who is engaged as a community participant. Um, as we're about to head into end-to-end review, we're in end-to-end review, we're about to head into the vote. Logging yourself as a participant in the project is a pretty critical way to participate in the vote, and I'm sure Sarah Bahal has it covered. But we'll try to make sure that that's in there, right? That allows you're on our listserv then to get information on upcoming meetings. And if you are like an ongoing involved community participant, it also helps you assist in the vote, which is coming up in a month or just less than a month. We're about 1 minute to go. There you go. Hey, see, Sarah Bahal. She's amazing. We do try to keep it up to date, but certainly the community, like the engaged participant status is pretty critical for the vote, and we're trying to get our voting membership clear. All right, I'm going to begin the meeting. Again, my name is Sarah DeSilvi. For those of you who don't know me, I am the Director of Terminology. I'm here with my friends on the terminology team, wrapping up end-to-end review today and like an off sequence meeting next week as we head to our vote in the end of November. Next slide. Thanks for joining. As I mentioned that, we mute folks. There's always open conversation. All calls are recorded and available on the Confluence page after, and we do have a robust chat. And please send chats to everybody so that we can really have a kind of a seminar as we go forward. Next slide. We are a HL7 accelerator, and so as an HL7 accelerator, we abide by HL7 accrediting entities, the American National Standards Institute standards for aligning with antitrust practices. So we just try to make sure that we are like not having any action related to prices, services, production, allocation of markets, and we don't want to discuss pricing or other pricing or any terms that might affect pricing on the call. Adherence to these guidelines involves not just obvious, but also anything that might be construed as behavior related to antitrust practices. So thanks so much. That's part of us being ANSI accredited in our work. Next slide. So we have a TRIM-focused agenda today, a quick announcements, and then really just a ton of work in end-to-end review. So we have a lot of new concepts. Our job is to have you all have transparency on the concepts we're creating so that we can look at them all, look as much as we possibly can this meeting and the next meeting so that there's no surprises in the vote that's coming shortly. Just a few, the slides are available on the Confluence. The masters are available on the Confluence. We'll talk about how to find them. But again, the mission is end-to-end reviewing concepts from now until the vote. Next slide. Just announcements. Next slide. Hi, Janice. There's a couple new announcements. So the technical work stream continues to work through, hi, friend, 3.0 updates. And we just had a lovely meeting yesterday. They meet every other week, Wednesdays, 1 to 2 Eastern Standard Time. We're heading to our next meeting on the implementation work stream, which is the same day as our consensus vote. November 20th is the next meeting. We're continuing our conversations on ROI. It'll be our last implementation workstream meeting for the 2025 year. So we kind of a reflection and wrap up on the focuses that we had this year. In terminology, really the big thing, besides the fact that we're trying to wrap up end-to-end review, is the incoming deadline for the ICD-10 CM submission that we presented in September. There's a period of public comment on, as per government process, on everything that's in the regulation sphere. So the public comment runs through November 14th. We have a draft letter that you can use to however you wish. The topic meeting packet is available on the Confluence. Like everything you need if you want to comment is available there. But just we wanted to make sure everyone knows that the comment period ends November 14th. It was very well received, Mark, right? And Mark asked a question, was it well received? Yes, because it's so closely hewed to the practices of the long-standing knowledge and expert and evidence base from the Kaiser Permanente CDC study and CDC approaches to date, right? So we were presenting within the CDC forum at NCHS, but we were doing so within lots of CDC friends. So it was very well received. And we did have CDC experts, of course, on our work. So very well received. And we hope to have those concepts. It would be next year if they were approved, next year in October, the October release cycle. Next slide. Any questions on announcements? All right, next slide. Who are we? Just brief update for those of you who don't know us. We are collaborative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. We are very, very grateful for our sponsors and members. We do have, I think they were here at the last time, but we're always grateful for new members. CVS came in. The family of CVS entities came in at a partner level recently. Super, super grateful for them, for any member coming in mid-cycle, but grateful for all of our members because we are truly a community organizing entity as accelerators are, and our many members make the work happen. So grateful to all of them. And also, as I always try to note that in our practices, we are the only accelerator that has a spot for members who can't financially support. It's the designated membership, and is to ensure that we have direct care CBO voices, community-based organization voices, and patients as part of our governance in line with our ethics and principles. Next slide. So this is a very important schedule slide because it has something that deviates from the norm. Usually, we meet every other week. In order to not conflict with Thanksgiving, since we have Thursday meetings, and in order to enable the timely submission of concepts for ICD-10 consideration and the deadline there, as a custom, we try to end the Thursday before Thanksgiving. That's what we try to do. So it's a little, in order to do that and have our meeting cycle, and start when we start, and to ensure that we have 2 weeks of review before the vote. Like we want you all to have as like the masters in your hands and plenty of time before the vote on November 20th. We're having an off-cycle meeting, and this has been on the schedule for some time, November 6th. And that is next week. And it is the last meeting in the end-to-end review period. And there should be maybe a few new concepts, but lots of definitions coming out of that work. There might be some, structural interventions coming in neighborhood safety. So we are meeting next week in not 2 weeks on November 6th. It's on the calendar. It's on the Confluence. You can find us in the same place and time, but just not in 2 weeks' time. So please remember that. We'll try to send a notice of that. We will send a notice of that out in our listservs next Tuesday, just to remind folks. Of note, we are likely going to be hosting a meeting on November 13th, not on new domains, but on some of our enhancement work that we've been doing. We did off-cycle alternating meetings for our enhancement work in the spring and last fall. So more on that. Again, everything, all notifications and emails and communications come through our listserv and terminology. So please sign up and get it and get connected so we can keep you involved. And please come back in 1 week, not 2 weeks, to finish end-to-end review on the concepts we've been working on this fall. Any questions there? Okay, great. Next slide. So the heart of end-to-end review is, we discuss themes here in the meeting, but the heart of end-to-end review is really looking at the master lists, right? So the meticulous and careful review of the master lists that have everything that we have elected to create so far and suggested. You can access them on the Confluence underneath the terminology workstream, underneath social risk domain build, on the Confluence pages for each of the fall domains: food access, neighborhood safety, and access to green space. These are the master lists that get uploaded on Tuesday evening following the public call. It's really important to look at them and we've already gotten some really lovely emails about end-to-end review comments. But if you have thoughts on the master list and end-to-end review, we need to get them in ASAP. And again, all comments entered in review are sent formally via email so that we can track changelog. But again, please download them. Master lists are posted Tuesdays, 5 p.m. Pacific time, and so they'll be next Tuesday. Any questions? I think we're doing good. Okay. Yes, submit, and we'll talk more about it, but all comments just come to the Gravity Project email. Next slide. And it's Sarah Bahal, myself, and Corinne, the program manager, who received those emails, so it's direct to us. All right, end-to-end review. Again, we're just refreshing the purpose. We've done a lot of creation work together and a lot of evaluation across our 3 domains. And so we really want to be thoughtful in our end-to-end review. So we look at those master lists and we ask if concepts are missing. And that's why I identified the neighborhood safety work. Like, we do recognize that there's some high level, like system level interventions within neighborhood safety that we still need to create. Are there incorrect concepts that need to be changed? And we do some wording stuff here. Like, if things aren't clear, we fix words. In general, some word stuff happens after the vote too, if we feel like the phrasing's wrong, but if there's something incorrect, we want to fix it. And we also are super frugal. So if there's something that seems unnecessary and it's like, maybe next time around we'll do it, because we always are working on enhancing prior domains. We also ask if things need to be removed. So those are the 3 primary questions we want to think about when we're looking at our master list. All comments are offered in written form with rationale and evidence for suggested alternate approaches. Again, we've already received and responded to a couple formal comments. Send comments to gravityproject@hl7.org, and then we send the comments unless the team already knows the answer, right? If it's a very obvious answer that we just haven't made explicit, the team responds, the terminology team. But if it's outside of something the SMEs have already communicated, we send it up to the subject matter experts for their review. Any questions on end-to-end review? Just making sure everyone's on the same page. All right, next slide. All right, and so we wanted to step back a little bit and kind of help everyone understand because we are doing our own internal end-to-end review as a team, really loose in the first weeks and months, and then we start to get more constrained in end-to-end review. We wanted to show some of the perspectives we're using as we look at our intervention concept specifically, and just elevate models for community intervention and literature. Next slide. Because everything we do in Gravity is evidence-based, so we have to point to something to ground our methods. So these are the 2 lenses we're looking at. On the one on the left, the performer of the intervention, we've talked a lot about that, like who's doing it, right? We've talked about person level intervention, clinical level intervention, and then community and collective action interventions. And so for reference, I'm like, what can I do, the person or the patient or the client? What can the provider do? And so I'm going to put my family practice hat on. What can I refer a person to? What can I provide a person in the presence of these community level risks? And then because we are working on community level risks, we are also necessarily thinking about communities and collection action. Like, what can we do, right? Including mutual aid, health system interventions, government entities, and policy, right? And so we've been talking about those 3, the performer, throughout. But I just want to make sure that everyone's aware and we're aware that we're also looking at the 3 on the left. So we also within healthcare and population health and public health think about the focus of the intervention, right? So who is it for, right? What am I, and if you look across the literature of social work and population health and even nursing, there's these three themes. There's micro practice, meso practice, and macro practice. So micro practice is focusing on like the interventions to benefit the person, patient, or client. Meso practice focuses on groups, peoples, families, communities, etc. There's a little delay here. I might turn my video off. And then oh, hi, Patricia's here. I have a meeting with Patricia tomorrow to have her help inform it. So she's already giving her wisdom. I love it. And then macro practice is focusing on system and policy towards systemic change. Again, Patricia is a brilliant leader in the social work field. We wanted to get an early view here, but I do have a meeting with Patricia tomorrow morning to help, and hoping that she can come in with her wisdom and help us refine this in time. So does this make sense? Again, looking from a completeness perspective. Hi, Mark. Yep.
So I'm thinking about sort of maybe a third column. What is the intervention? And I'm wondering if the intervention at the person level or the performer level will always be different in some way than the intervention that happens at the community level. And the easiest way, the reason this came to mind, I was thinking, so maybe person level interventions get one set of codes and community level interventions get a different set of codes. So I'm sort of generalizing that thought to say, is what we name the intervention always going to have a different name, even if there's some sort of similarities at the individual level and at the community level? Thanks.
Yeah, Mark, this is actively something we're working on within our, um, within our team right now, N10 Review, which is why we brought this forward. So finger on the pulse per usual. Right. And it's partly why I'm meeting with Patricia tomorrow, right? To just really think about like how we frame that, like whether different concepts are required, and like literally different names. We definitely are working on different names for the problem statements, right? Because we don't want to conflate community housing security with individual household housing security. They're different things. But very much this is the work we're coming into, and this is again what we're trying to sort out with N10 Review. And there's both conceptual considerations, like is it the same thing? And there's also like terminology considerations, like can we use it in both places given the requirements of the terminology of reference, like SNOMED. So these are definitely, it's like where there are things we're thinking about right now, and partly why we elevated this, and hopefully leveraging the wisdom of folks will get to a good answer, both again from the conceptual side and from the terminology side. Hello.
Thank you.
Hi, welcome back, Owen.
Hi, thank you. Thank you. It's a quick question. So when we're talking about evidence-based on evaluation to make sure that we are hitting and our implementation get evaluated and see if the outcomes that we are pursuing are getting done, or if we are moving forward. In terms to social determinants, when we see the individuals at a holistic level, what will be the center of the indicators? Are we talking about the health outcomes and the social determinants? And the reason I say that is because when we're talking about the root cause of the problem, and which one of the root causes can be addressed based on resources and common agreement of partners, then best practice will be identified and implemented. So, and they will be related to the local data sometimes in terms to, a county or a neighborhood could have different root causes or diseases or conditions. So yeah, I agree with Mark in terms to columns or groups, because the process, how that is done, the analysis of the data to find out the root cause, and then which ones we are going to address that are more feasible for different perspectives, and then choose the best practices is key in terms to implement a best practice, because I don't know if you get what I'm trying to
No, I
say.
hear what you're saying. I think I do. I'm going to try. So number one, regarding outcomes, we have a whole presentation, we have a whole approach on outcomes that that I can pull back and like link next meeting when we come back, because we think about outcomes, certainly measurement from all these different angles, anyway, there's a long, there is a very long, like a presentation on that. And specifically when it comes to what we do in our subject matter expert meetings, is we ground ourselves at least in the evidence that this intervention works to address this metric, right? So we have to say, is this a neighborhood safety intervention that's in the literature, right? And so certainly you can trust that every single concept that we will present to you today has some evidence in the literature as moving the dial, and Asha can attest, and Sarah B can attest, because our SMEs, when they're doing their own end-to-end review, they're like, actually, this is not clearly aligned with the literature yet. Let's pull it back, right? Or actually, this one, it's so that all of that is happening as we're trying to create a set, because we never expect to be totally encompassing of all of the things that work to address the problem and all the possible outcomes. We do want to offer an evidence-based and valid set of suggestions aligned with the domain of reference. Great. Okay. And again, Lucy, hi. I'm trying to, hello.
Hi, thank you. You can hear me, right?
Yeah, I can. Hi.
Okay. This idea, interventions based on the focus of the intervention, is not only core to social work, nursing, and population health, but it's core to all politics and
Yeah.
many spiritual practices.
Yes.
Therefore, it occurs to me that the that the person assigning these codes to a particular encounter is bringing necessarily spiritual and political assumptions to the code that they are going to assign. How are we dealing with that? Like somebody who is, I'm just plucking this out of the air, deep into Buddhist practice, encountering a problem, may be focused on the person, patient, client level of intervention more than the macro practice. I'm just trying to grapple with that. There's no question that how to intervene on multiple determinants inevitably gets to politics and philosophy. And how are you and the SMEs dealing with this?
So I don't have an immediate answer for you because I haven't asked the SMEs that question. Patricia's here, so she can talk about it. But I want to note that there is a difference between policy and philosophy. I mean, I'm sorry to putting I'm a philosophy major. Right. So we do operate from the World Health Organization conceptual framework for action on the social determinants of health, which requires that every healthcare person advocate in policy in order to achieve health equity. Right. So there is that simple statement of fact that policy drives systemic change. Right.
And politics drives policy, Sarah. You
Correct.
just
I know.
cannot get away from that.
I hear you, but that's
Okay.
still a little different than philosophy. So let me go back and get better answers, and maybe Patricia wants to say something, but I'm just going to note that that our current framework is on policy, right? And policy that's supported by evidence. I haven't asked them about philosophy. We were talking about nonpartisan policy today. So if you can let me hold that and bring it to the SMEs and come back, that's the only way I can authentically respond, because we have not talked about that with SMEs yet.
I just want to raise awareness about this. I don't expect this to be resolved because
Okay.
the question that I asked and the answer that you are giving has animated political scientists and philosophers for centuries. I
Correct.
just want to be sure that everyone on the call realizes that we are touching on very individual assumptions about how change happens. Thank you.
Thank you, Lucy, for that. And I look forward to talking with the SMEs. And Patricia, did you have anything you wanted to say? I saw you come off on camera. Do you want to talk
Well,
tomorrow?
I think it's a point well intended. There is that direct relationship between, really philosophy, policy, the political system, and so forth. I was just going to mention, and I put it in the chat, our newest classification for the WHO is centered on health interventions. And we had a very similar discussion years ago. And so we have basically addressed it in a kind of uniform, because it is a classification and terminology. It's meant to go into electronic and digital systems. So we had to have some uniformity in our approach. So we do uniform, and this probably is a longer presentation, but we look at micro, meso, and macro interventions through key points, which are like targets, means. Target is basically where we want to intervene. So it could be intervening at an individual level with persons. It could be at a group level, family level, community level. It could be the environment, for example. So we do it uniformly, and then we have a means, which could include, if we're looking at a health intervention, like a surgical intervention, could be a specific technique. But we looked at it also broadly when we think about policy. So we have policies like economic policies, for example, as a method in there. So economic instruments, tax structures, and so forth, incentives that could be very instrumental in how you might look at moving the needle, if you will, as an intervention to address social determinants of health, for example. And then we also have things like actions, and we have advocacy, for example, in there. So I was involved in this, of course, so other people who are clinical professions that believe very much in social determinants of health, we were able to get things that are quote unquote non-medically related in there. So this is something that I think could be very interesting to the Gravity group. And I know we're meeting tomorrow, but I think we have been able to kind of grapple with some of these things that were just mentioned in that comment, because it is inevitably reflected, right? In our policy and the decisions that we make in how we build these systems out. So that's my 2 cents for today.
And then the hope part of why so Patricia, she's lovely and brilliant, and I appreciate you. We do want to make sure also that if like we always try to build off the work that's already been done. So if there are concepts in ICF that already establish these kinds of interventions, there's no reason why in Gravity we wouldn't actually just rest our anchor and terminology on those, and so we have harmonization. That's the point, right? So looking forward to bringing that back. And Patricia, I appreciate you. You know that.
Being here. Sorry, I can't come more often because this is always such a wonderful group of discussion. I appreciate this group so much.
We appreciate you too. I get to have coffee with her tomorrow morning. Okay, so onward. We're gonna keep on trying to go forward. But then again, Lucy, thank you for your brilliance as always. We want to make sure that folks know at least that this is the lens we're taking as we look through our interventions right now, and specifically like from Are Things Missing, right? We have a fair number. Our work in Gravity to date focused a lot on micro and meso practice, right? And not as much on macro practice. I think that where we got to it was in, some of our work in health literacy or racism, we touched upon that. But really, in order to do these community level risks, we have to think at that level. So just note that we're trying to approach it with that lens. All right, here we go. Keeping on. I know. Wouldn't it be great to have a seminar with Dr. Salibi? Next slide. Okay, we're going to try to keep going. And so one of the things, and again, this is just exploratory, but so we just went all very deeply into these opportunities within macro level practice. And I already said that historically to date, our intervention framework is really focused on the micro. Like I'm referring a person to something. You don't refer a community. Right? That's not what happens, right? There's possible provision, but a lot of the activities that we have, again, reasonably, because we were focusing on household and person level interventions, are in that micro lens. And so we raised this last meeting. We really, we really do need to step back and think about what, and again, we'll make sure that we align with the work that ICF has done to date and WHO. But we want to make sure we step back and think about what is the syntax for a community level intervention. And we have initial hypotheses on the next slide, and these already exist in, you know, there's terminology precedent for these. But if we go to the next slide, you can see we start to think about like the verbs being develop, right? So what we're talking, and again, more to come here, but community development is the heart of the intervention of community development, and community development professionals and collective action are the heart of what we're thinking about really at the macro level. And then we're exploring a concept for maintaining, because you don't just develop programs and policies and processes, you have to maintain them. So again, a first effort in trying to represent macro level interventions, given our syntax, for the intervention framework really has been micro level to date. Pulled from the profession of community development, the concept of develop is anchoring in activities that build or strengthen community capacity, infrastructure, and resilience through collective action. And that capacity word, we think about the fundamental like capacity building work, you know, and capability statements of individuals like Amartya Sen, right? This is like fundamental to the work of population and public health. And then we have, again, building off the community development professional and resource work, we have maintain being activities that sustain or reinforce community assets, relationships, and systems to preserve well-being and resilience. These are all evidenced, these are all referenced in the National Association of Community Development Professionals. Again, exploring these definitions as we go forward, but we just know we didn't have the syntax and structure to talk about what we do in collective action and talk about what we do within the realm of policy. So we're trying to address that here. Any initial thoughts here? We prefaced this 2 weeks ago. We said this was coming. We mentioned it. Yes, I hear you there. Oh, and yes.
I don't know. I have a thought that I don't see they will could be included right here as a note in terms to social determinants of health and how we wanted to impact the individual, family, and community. We know how policies, laws impact the environment that we live, right? So in terms to collecting impact, because we cannot change the way how laws are made, and it is what it is. Sometimes, you know, depend on the philosophy, how the problem is going to be solved. But one of the issues that we have is kind of recurrent is sometimes the law gets short in terms to solve the problem a little bit more deeper. So in terms to calling the impact, that will be a good idea to have best practices. They can complete the work of the individual of the law to improve wellness to the neighborhood, or family, or county, or state. So I don't know if you know, understand my point. Thank you.
I think I do. I think I do. Do you feel like this is a good path forward for, you know, again, these macro level interventions? Is that?
Well, it's because it's so much invested, you know, when the people vote, all the resources the government use to generate investment from the private sector, but also government investment in communities is most of the money, but it's still in turn to solve problems that are in a better way. Sometimes the law gets short, but social other programs that we can find and add to that, like a SNAP. Maybe a SNAP need another phrase to complete that, and that way that family at some point will be healthier and more independent. But the way how law is created is because maybe it's no more resources, it's no more you know, desire for depend who have the control of the party in that moment when it was created, it was limited. But it's a lot of resources that can be because it's a lot of energy, they get lost because it's not complete the job they intended to, I think. Thank you.
So I think if we start to see examples of some of the macro level interventions, it will make more sense. I do want to make sure that, Owen, you hear that we're talking about both political strategies and collective, independent, non-political strategies, because both are important, right? Communities and collective action, not just within like legal frameworks and policy frameworks, that's critical. But also we're talking about some of those more structural policy legal frameworks as well. We're trying to develop both. And I see Patricia talking about Nussbaum and Sen. Huge fan.
That's what I used for my dissertation
I
26
know she
years
was like, I got
ago.
to study with Nussbaum a bit when I was doing my doctorate.
Chicago. Yeah, she's wonderful. I
Yeah,
wrote a
sorry.
chapter in the
I
book,
know.
but I do think that will touch into even some of what Owen is saying,
Yeah.
especially in today's political climate here in our administration. If you're interested,
Yeah.
you should read, just came out a couple days ago, John Palfrey from the MacArthur Foundation wrote a little piece in The Economist about how philanthropic organizations are under attack, right, with administrations trying to direct them into what they should fund and not fund. And I commented recently on his post that basically, to Owen's point, is that we have limitations, as we know, with our laws. And I think Lucy had commented too. And for whatever it's worth, we have some influence. We don't have, maybe less so nowadays, but philanthropic organizations are trying to step up, right, to fill in that gap. And so I think we might have even more. That's why I think this group is so important, that we have probably more influence to help to direct, if you will, these philanthropic organizations that are putting in, like MacArthur and Rockefeller, like Food as
Robert Wood
Medicine, for
Johnson.
example, right? Robert Wood Johnson. We have an opportunity to really direct, and I would love to be part of, and then if others are interested, out of this group, that come out with a piece, a kind of a think tank piece that basically says to foundations out of this group, this is what is needed. This group collectively of experts that representing many different diverse perspectives, this is what we think foundations should go, the direction they should go. And I think it could be very, very powerful.
I love that. We're trying to get better at representing the findings of our work as TEP findings, because we realize that they are. So I think that I love that idea. I want to be careful because we haven't even gotten into the content yet. So I need to I know we have to do end-to-end, you have to lay eyes on everything and end-to-end review. So I do want to make sure that we get to the content soon. So any other last minute thoughts before we get into
my hand up.
content?
I just want to say that a perfect example of this is what's happening in the moment right now around food insecurity, where multiple communities are going to, coalescing, like behind the scenes. I've been writing to leaders of some of the local nonprofits that I work with. What are we going to do here? People are giving money. Where do we give it to? Some people give it to the individuals, but it's really coming out on Facebook and social media where, the collective is coming together to help individuals. And so, and that's not often captured, right? And particularly if you live rurally, that happens a lot, neighbor to neighbor type of thing. Thank you.
Thank you, Janice. Lucy, any other final thoughts?
Sarah, if you go back to that slide where this incredibly philosophical discussion started, I think maybe under macro practice, you have a paren, meso, what that means, macro practice. Maybe some parens here are in order. Philanthropy would be a paren here. And I have to direct everyone on this call to Laureen Powell's Wall Street Journal editorial recently about what philanthropy really is. It's not a way to curry favor, which is the way some philanthropists are now using it. It is a way to empower communities. So somebody needs to get that link. I'll be happy to send it to you after this meeting if you want. But it's really very basic to talking to philanthropy about what's important, especially now. Thank you. Bye.
Thank you. All right, we're going to go back to we're going to skip forward and try to get to the content now. Thank you. Okay, thanks for your patience with us as we work in this new area, trying to make sure that we represent macro level interventions, because you do not solve community level problems one person at a time. You can't like a food box does not solve community food access, right? So we have to think at the macro level if we're trying to actually address these concerns. And of course, it's based on our fundamental framework. You know, again, we are World Health Organization conceptual framework folk here. Okay, thanks for your patience. Next slide. All right. I see your timing concept, Mark. We'll take it back to the SMEs and see how it goes with the hopper. I see it. All right. Asha, do you want to walk us through standardized instruments for neighborhood safety?
I would be happy to. Thank you, Sarah. Good afternoon, everyone. As we have gone through this process, we have already talked about the National Institute for Justice's NIJ measures of community perceptions. If you would like to review the items that the SMEs advance, please do go to the Confluence and pull down the master file so you can review those. But we do have something new from the neighborhood scale, from the safety section, and I will show that now. So this question, the SMEs felt was important, and it reads, the violence is not a problem in my neighborhood. And the answer concepts are on a 5-point Likert. And the reason why our SMEs felt very strongly about this question is because of the difference between crime and violence, and they wanted to highlight that, and to have a question that specifically address violence in the community. Because as you know, crime is a legal term, it's breaking the law, right? But violence are acts that cause or threaten physical, emotional, or psychological harm. So violence can be a crime, but it also can be systemic or interpersonal. So our SMEs thought this was an important question to ask because we're asking about lived experience and perception specifically in this question, and not just crime rates. So this was another item that was added to the value set, and then we can move on to diagnoses unless there are any questions about that. Okay, hearing none. Oh, wait, Mark.
Sorry, it wouldn't come off mute. Yeah, I'm curious, is it, in answering this question, would it be a possibility that one could be experiencing violence in one's household and still think that violence is not a problem at a neighborhood level?
We can look deep into the cognitive testing and implementation of the instrument to make sure that that's not conflated. And also we'll ask our SMEs whether it matters. And I hate to say it so plainly, but
No,
like,
no, that's fine. That's fine.
does that make sense? It matters
Yeah.
because like, you know, like to honor the lived experience of individuals with intimate partner violence, maybe it doesn't matter if it's inside the home or outside the home, if it's a signal for help. So we're going to try, we'll take it back to the SMEs and we'll ask and we'll come back.
No, I think that's right, that it doesn't, at some level, it doesn't matter.
Yeah.
But to understand how to read the results of an answer to a question.
Exactly.
Yeah.
My guess is
Thank
the
you.
cognitive testing of the instrument explored that. And there's also a preface that we don't have here. There's a heading for the question approach that's not in the representation. So it's a
Thank
little
you.
bit, we're pulling it out, right?
Yep.
Owen.
Because there's so many questions that we had to make. I think these questions look good, but also when we talk about social determinants of health, we know is when we work, when we study, when we do different things, and neighbor could be just the place where I live in the night, but I had to go to school, I had to go to work, my kids had to go to, but for the benefits, it's too many questions. It's hard. Ideally, we have the framework of as less violence in my city, there will be less chance that I have in my neighbor. But there's more a vision of safety in my community and my county. But I think it's hard to have the right question.
Yeah, and I think we are definitely talking about the geographic area being measured in certain ways. In this instance, we're bound to the method of the questionnaire, right? But definitely in our concepts, we're trying to think, creatively, certainly though grounded, we are taking for these domains based on the literature, we really are grounding ourselves in the where I live component of the geographic, because that's where the lit has us grounding ourselves. Not necessarily where I work. Like for instance, if I live in Arlington, Virginia, but I work in DC, right? We are focusing in the where I live part for these domains so far, but acknowledge everything you just said. All right. Any other questions before we go on to diagnoses? I love that Denise's retirement home has Wall Street Journal. I just love that. I love you, Denise. All right, next slide. Okay, we're going to try to get through, again, what I note here is we might not get through all the content today. There's a lot of content. Enter Review always has a lot of content. It's okay because the master list has it all. And the slides exist, right? So even if we don't get to everything, you can see the slides on the Confluence and the master list will be there, and we'll be here next week as well. Next slide. We are related, Owen, to what you were saying. So we're having conversations as our terminology team and as our subject matter expert groups on how to represent the physical location part, right? Because what we know from our data sources and instruments is they're the highest level, like environment concepts, but the measured entity changes depending on the instrument and the data source. Sometimes it's census tract, sometimes it's census block group, sometimes it's health service area, sometimes it's neighborhood, right? And so we had a huddle with our dear friend Corey on Tuesday, really trying to think about, some kind of taxonomy of place, really, like the highest level statement on place and a path forward. And because there's not going to be a combinatorial explosion, I'm trying that word, Asha, we don't have a lot of concepts of place that matter. Really, we're thinking about, there's like 5 that come up in our data sources and instruments. It's wise to think about this highest level concept, this in physical environment that there's precedent for in ICD. That's how ICD talks about place right now in C58. And then we'll likely build room for constraining. So if a health system wants to say, I'm constraining it to my health service area, that's possible. Or if a community wants to do community block group, that's possible. And if a census, whatever, there's all kinds of possibilities for constraining to the unit being measured. But what we know is we need the highest level in physical environment. And we also know there's precedent for that in classification within ICD and within SNOMED CT. So this is our first step as a general physical environment parent, insofar as, Owen, how physical environment affects health. And then it enables subtypes in time. Does that make sense? Okay, great. Okay. And just note, there was no Z58. There was no physical environment location within ICD until Gravity birthed it again from the ashes in 2019. Like ICD-10 had sunset everything in the Z58 series. And so the physical environment section of ICD was brought back by Gravity in 2019, which is amazing to me. Next slide. We'll kind of get through. When there's not updates, is it okay for the sake of time if I just move through again? I just want to make sure that we're highlighting changes. No changes to these diagnostic concepts on this slide. So now we're going into goals, and I hope it's okay because we presented that content. Go team, Lucy. So I'm going to talk about edits here. This was a misspelling by me. We talked about social connectedness, but we actually meant social connection. This is an error on our slide last time. The only other new change is really building into that civic engagement, civic muscle concept. Lucy from Vital Conditions, we've talked about this for some time. And so this is a concept, civic engagement, that we had from our past work in protective factors and ACEs that we brought into this work. It already exists. Interesting, Denise. We'll bring that to our SMEs. Again, that's not necessarily like an end-to-end review comment. So it's not, but we will ask that question of our neighborhood safety SMEs. Thank you, Denise. I can see Asha capturing it. I love it. Sorry, we're doing it. All right. This is the social connection, spelling change, and the addition of civic engagement that already existed from our previous work are the only additions here. Next slide. Please download the master on Tuesday and let us know if something's missing, not necessary, or needs editing. So now on to interventions. Okay, wait a minute. Before we go here, there is a lot of content here because our subject matters took time to represent all of the evidence-based interventions highlighted by the CDC in their approach to community safety. So brace yourselves, right? The fundamental paper, again, oh, and this is evidence. That's like CDC was like, this helps, and it's structured in different sections. So there's a lot of new content here. Most of it's at the person level. So this is why we do have some macro level concepts that we're working on. We have the model that we presented to you some time ago to help us with that. But for right now, there's a lot of concepts coming. Okay, fasten your seatbelts. Next slide. And again, everything in here is the CDC highlighted in its summary paper and statement, which we'll put in the chat, on approaches to community safety. There's evidence within it. So, oh, sorry, if we go back one slide, just because, so the CDC structures its interventions in different components, so in efforts to address community safety through strengthening economic security, which is one of the approaches they had in the paper, they highlighted federal earned income tax credit, federal child tax credit, because this is all about building wealth and addressing the economic, like disruption and disease of lack of wealth and lack of economic opportunity. I'm like tripping over my words. So they have, these are all the strengthening economic security concepts. So we have EITC, CTC, low income housing tax credit. TANF was already a project from our financial insecurity work. We collectively created a universal basic income. Unemployment insurance already existed and Medicaid already existed. So these are, so existing means it was part of a different domain. Every single one of these things is called out in the CDC paper as approaches to addressing community safety within strengthening economic security. Hi, Patricia.
Oh, I have a question. So if it's something that is not, and I haven't looked specifically at this paper, but if it's something else that's an alternative to this paper but has evidence to it, is it
Yes,
something
bring it.
we could? Because I'm just
Please.
thinking of something like baby bond. Like I just had a dinner with Derek Hamilton who created baby bonds, right? It's
Oh,
that
yeah, love
that
it.
addresses wealth gap. It's all that
Yeah.
wealth, gap stuff, racial wealth gap stuff. So that might be something interesting, and that's been tested and it's been implemented in multiple states. So something like that. Okay.
Yeah, they actually highlight wealth development and investment in bonds in the paper. And so we hadn't actually had a great, but I'm going to admit the programs they highlighted weren't easy to represent, whereas that one is. And so there's this kind of gap because the only concept we had was a concept that came from our work on financial insecurity with the Financial Health Network, which was this national representation. Yeah, so please, Patricia, send it over. That's perfect.
Do I just send you, what do I send you? Or someone could put it in the chat. Maybe Asha can put it in the chat what I need to send.
Oh, yeah. So if you just want to send an email to gravityproject@atelscenter.org.
Okay.
Yeah.
Got it.
And that's it. N10 review. Send us the paper. Go team.
Okay.
Yeah.
Thanks.
Okay. All right. Great. Thank you. Okay. Next slide. I'm just trying to make sure. Okay, great. In the CDC paper, in providing quality education as an intervention toward community safety, we have, again, we just took literally the thing the CDC was saying, this is an intervention. And if it's existing, we're saying it already exists. And if it doesn't exist, we are proposing that we should make it. School enrichment programs, which are really like community action and enriching like non-curricular activities within school. And I just had a million programs that Asha had to hear me, like suffer me talking about in my community. The next one is something that we recognize the wording's a little odd. They talk about family and education partnerships. We added accessible because we recognize that often family and education partnerships like the PTO or PTA are not accessible. We're trying to figure out the wording on this one. Our SMEs as well, we're like, we don't know what that means. And we're like, we get it. But we're trying to represent what the CDC said is, family and school partnerships toward the embetterment of the quality of education at the school. and like collective action focused on school family relationships, right? So we'll figure it out. If somebody has a better idea, again, this is an end-to-end review comment. So if you can send it to gravity@hl7.org, Gravity Project at hl7.org, that'd be great. Again, all evidence-based programs in the CDC framework. Next slide. Oh, Mark, hi.
So you think that concept is trying to capture not family partnerships, not education partnerships, but partnerships where both family and education are connected?
Yes, there's a lot of partnership concepts in the community
Okay.
work. Yeah.
I will drop a suggestion in the chat. Thanks.
I
Bye.
love it. Yeah, because you'll see in food access, there's other partnership types. We're really talking about this and this partnering, right? There's those farm and community partnerships in food access. So yes, thank you, Mark. Next slide. Oh, this is so fun. Okay. Enhancing instead of accessible. Yes, so we said we'll figure out that word, Janice. Yeah, because yeah, well, thank you for the enhancing idea. So in creative protecting environments as the intervent, Mark, do you have another thought?
No, I didn't lower my hand. I'm sorry.
Okay, okay, I'm trying over here, cat herding. Okay, so in creating protective environments within neighborhood safety, we already had, so they talked about lead remediation very extensively within the CDC work, and that already exists from our inadequate housing work. And then we also have these programs highlighted in the CDC work. So firearm safety programs, community alcohol policies, which we're recognizing the wording needs to change. It's really when communities get together and like define, it's kind of like instead of food swamp, it's like alcohol swamp. When there's too many alcohol purveyors in your community and it's overloading, there's great evidence that that's problematic, and intervening to address it can be really protective. So we're working on the wording there if anyone has a wording idea. And then Safe Patches programs, lovely. So Asha and Sarah and the Smees and I had this lovely moment reading about Safe Patches programs, which is when communities and collective action rally to allow children to walk safely to school. Chicago had this beautiful example. And again, an evidence-based program that not only is connecting kids with that non-parental adult that matters, right? It's connecting them to their community because they're seeing that they matter within the community, but it's definitely a safety intervention. Again, CDC, evidence, go team. Next slide. Oh, why not community drug policies? Because I think the thing we're talking about, this is like the reason why the community alcohol policies, because they're directly something you can help with, okay, suffice to say, we'll bring it back to our SMEs. This is specifically related to the literature on the presence of alcohol purveyors in a community. If there is literature associated with drug use and drug, I'm sure there is, we'll bring it back to the SMEs and look at it. Denise, does that make sense? So we were trying to represent specifically the alcohol bit in the CDC paper. Everything that's in here is CDC mentioned. Got it. or it exists and we'll find it. Owen?
Sarah?
This is,
Oh, sorry.
sorry, you go ahead, Lucy.
Yes, there are community alcohol policies. I recollect that after a major earthquake where I live, the first thing the mayor did was shut all the liquor stores. And so I'm wondering whether community alcohol policies, either in the literature or in our future discussion, could branch into emergency versus, I don't know, policy. Because in emergencies, closing liquor stores seemed to me absolutely brilliant. And I was not the
It's a
only one to
community
think
safety
so.
intervention, right, Lucy? Like that's
Exactly.
yeah. Yeah.
Exactly. So I'm just wondering if we could refine community alcohol. Someone who wants to work on this at the macro level, if they're talking about emergencies, may get further initially than talking about this as a general community issue. We don't need so many liquor stores.
It might be still community alcohol policies. It just might be good. We're addressing disaster, I think, in the fall. Aligned with,
Okay.
yeah.
Okay,
we
that's
have-
cool. Let's put this on the back burner then.
Love it. I know.
Closing,
Nice to be able to
closing
say,
access,
Yeah.
closing access to alcohol in disasters could be very significant.
I
Thank you.
love this. In
Just
the
to be
parking lot.
honest, people die when they're alcoholics. They don't have alcohol. So
Correct.
there is
Correct.
another side to that whole emergency issue. Yeah.
Yeah. Yes, I hear that too, Janice. So this is about limiting. This concept's about limiting, not stopping.
Yeah.
Right.
Got
Yeah,
it.
it's about really, I think the best correlate is the food swamp concept we have in our food access, right? It's about the proliferation and dominance of resources. So thank you for that, Janice. I appreciate you always. All right. Keeping on, creeping on. Oh, Owen, hi.
Yes, I don't know if this one is linked with mental health, because one way that you limited the alcohol consumption also is maybe the reason why people are drinking. Maybe some people need to drink because mental health or issues. I don't know. But
Yeah, so I'm an addiction medicine specialist. Hear you, like trauma informed, like there is not a single person in my panel who does not have significant trauma, right? Like this is the nature of this is sorry, it's really emotional. Yeah, so thank you for that. Yes. Okay. Whew. All right. Next slide. All right, so in interventions, Mark, okay, it looks like he has a dot. Mark, I'm sure you're going to be putting something brilliant there. So in the next level,
It's a joke. Never mind.
Okay,
It's
okay.
like
I'm trying. I'm in facilitation mode, so I'm just
the
trying to.
community. It's community alcohol, like everybody participates.
Oh, okay, got you. Okay, great. Okay, I love that I'm so like focused on the mission. Asha, I'm trying to keep us on target, friend. That I didn't get the joke. My apologies. Usually I get jokes, but not today. So in promoting healthy family relationships, intervention concepts, I just want to note there's some things that aren't like, I want to just thank our SMEs for being really super careful about things that are not sufficient, right? Like they very much are taking this lens of like if a concept is not evidence-based and powerful enough, they're like, no. Like there are concepts that we suggested because they exist in other domains, you know, or they existed in the paper, and they were like not evidence-based enough. So just it's me's props to you. So in promoting healthy family relationships, I thought actually, Patricia, this is what you were talking about. You were talking about baby bonds. I thought you said baby boxes, and I was like, we love baby boxes, but that's not what you were saying.
No, I wasn't.
I know. You said baby bonds, right? But we actually are talking about baby boxes here. So we have lots of early childhood. And again, this is, Asha, you can probably speak to this better than I can because this is your area of expertise. Early childhood home visitation programs, specific subtypes of perinatal home visitation because of the critical nature and the evidence of supporting families in transition. We have new baby kits because it was mentioned. This is something that exists across the ecosystem as a public health intervention. Every newborn baby getting their box. It's like Finland was the early adopter in this, like way back in the Wayback Machine in the 1950s, I think. 40s, no, it was 40s. It was like 1938. Nurse perinatal home visitation. We want to differentiate nurse-led visitation just from layperson from layperson visitation, parental support groups, family strengthening programs, and Head Start programs already exist in our set, but those first four are new. Janice?
Just want to add, I just was with a group of people where, anyway, we're working to develop respite opportunities for California and Washington, but it's nationwide within a hospital system in 27 states. And anyway, one of the fathers there works in California, and he runs a father support group. And I just want to emphasize this when we have parent support group, because there is such a lot. There's so few father support groups, everything from, single fathers with children to, that are, barely making it, to people that are, and, a divorce, a death in the family, to reentry. But they are so beneficial. And I just want to add to be sure that we have that in there.
Thank you so much, Janice. That's why we use the inclusive word parent, right? Because we want to make sure that we're not just, that we are being inclusive. And I, big fan of dad support groups. We have a lot in my community. I see Denise's comment. Yes. So far, this is built upon the literature and the CDC working with the SMEs to represent the concepts within the CDC literature. So based on the paper, I hope that makes sense. And then Owen, I hope I answered your question. Owen, before we move on.
This is a weird comment, but when I work in maternal and child issues in terms to providing or try providing a space to discuss some poor health outcomes with the existence of some of these programs, one phenomenon that I see sometimes is the people who run these programs have a hard time to have more space for other programs.
Oh yeah, I hear you.
So one of the best practices that will be great to have it when in addition with one of those is to analyze root causes on an ongoing basis, because they kind of start getting we kind of start getting blind based on the how we love a program and don't allow other programs to other ideas, other issues to be seen. And then if you don't see the issue, you cannot identify another best practice that maybe your community needs. And the reason I say that is because we see how health outcomes in maternal and child in African Americans and Native Americans have been for decades and decades been not that great with the use of those evidence-based. So there are things that we don't know yet. There are so many things that we don't know. And that space is important to keep and defend and to talk about it, because it's an ongoing search. So I don't know how,
Okay.
but that's what I'm saying. Another best practice would allow the implementers of this evidence base to search if it's anything they are missing and they need to be addressed at some point.
I want to thank you, Owen, for that. We do actually talk often about the limits of what the CDC has studied and is evidenced, and the things that are not being studied because of like who's choosing to study what. So thank you so much for that. And you actually just reminded me of, one of my, so Asha, we're trying to think about like concepts regarding, collective action. And it's interesting because my first introduction to the Prevention Institute, who's one of our cross-domain subject matter expert, was in the development of accountable communities for health, not accountable health communities. Okay, not the AHCHRSN, but the concept of an accountable community for health, right? We all come together. And that was my origin story to population health, as I ran my health service area as accountable community for every single nonprofit, every federal entity, WIC, Planned Parenthood, the SNFs, the hospitals, the FQs, we were all in a room. And it was the collaboration was the goal, right? And it was the idea that like mutual aid amongst entities, like not just amongst community members, like how do we help each other? Like help our people, right? And so maybe we need to make an accountable community for health concept, Asha. I know. I know. I'm sorry. I'm like, wait a minute. This was all the beginning. Anyway, thank you so much, Owen, for you enabled this epiphany, right? Because that is where you get the organizations collaborating toward collective purposes in those kinds of settings. So thanks for taking us there. All right. Next slide. I think we're doing good. I'm trying, Asha. We're doing okay. Okay, so in strengthening youth and young adult skills, which is again CDC related, there's a host of concepts we had from our less than a high school education concept, because it fundamentally focused on youth and trying to help them attain, success in, vocation and education. So we really just, everything the CDC mentioned, we were able to just dump in, because that was exactly the population we focused when we did that domain. So everything exists. We just pulled it over from less than a high school education. Grateful for our work back in the day. Next slide. And then this is still building on skills. We like this is still just coming from our less than a high school education work, or it's coming from our digital access work. Again, just running down the list of things. And then there's also interventions from our ACEs work in the spring as well. So we literally just went down the list of CDC evidence programs and got to do, like I joked, it was like the Golden Corral buffet. Asha and I were like, and Sarah were like, this exists here, and this exists here, and this exists here. All the literature, all the concepts and terminology that we've addressed in prior domains. Next slide. And those will be on the master. And again, same thing, connecting youth young people to caring adults and activities as a CDC intervention macro, we had all of these concepts again from our ACEs work, from social connection. You know, no social determinant exists in isolation. We are all a Venn diagram of needs and a Venn diagram of strengths. So we were very lucky to just pull stuff in from our prior work. All right. We just got through neighborhood safety. This was a huge jump of new material. Next slide.
No, one more.
Oh, no, no, it's one more. So sorry. I'm trying here. So intervening. So this is actually structural intervening. Ash is so patient with me. I'm in facilitation cat herding mode. Intervening to lessen harms and prevent future risks. This is actually primarily all structural stuff, right? This is like, how do we work in community? We already had trauma-informed network from our ACEs work and toxic stress work in the spring, based on the pattern of the work in California and around the nation. We didn't want to just have the provider. We wanted to step back and bring up to the actual development concepts. If you don't have a trauma-informed network, you have to make one. Again, we're thinking about our macro interventions. And so we actually just flipped the words around to a network of trauma-informed providers. To encompass things like the California approach, communities that care approach is an example. Again, so from the UW School of Social Work, kind of the macro interventions. And so those concepts were built off of things we'd named before, but adding the actual development of the network from a macro lens. Hospital-based violence intervention program was in the CDC work. Street outreach program was in the CDC work that already exists. And then we really are trying to think about, in every single instance, in each of our domains, what is the evidence-based name of the kind of partnerships and collectives that communities work on, that create to address this problem. I said accountable community for health at the highest level, but in our literature, we had community policing, we have community justice partnerships. And so at the highest level, the evidence points to neighborhood safety partnership. So if you don't have a collective in your community that's working on concepts of neighborhood safety, the lit talks about these kinds of entities within communities specifically, and involving justice involved folks, involving education folks, working towards common purposes and goals. Deep breath. Okay, so this is the next slide. I think we're there now, right? Okay, that was all neighborhood safety. A huge jump of concepts, and I'm going to try to keep us going because we don't have very much time. And so if you're all patient with me, we're going to revisit the end-to-end review again next week. The masters exist on the Confluence on Tuesday. I'm going to try to keep us going just to show new things. All of that was new, so it was worthy of our moment and our time. Next slide. Food access. Next slide. This is the framework from Usher. We ground ourselves in this. Next slide. Next slide. Asha, do you want to go for it?
Yeah, got it very quickly. So again, if you want to review all of the standardized instruments that we have approved already, the SMEs have already approved, please go to the Confluence and review the masters. We have the Medical Expenditure Panel Survey, MEPS, the Social Health and Experience Survey. That actually, when we went to review the origin of that survey, led us to the Wellbeing and Basic Needs Survey by the Urban Institute. So we're just correcting the attribution of those survey questions. They came from the Wellbeing and Basic Needs Survey. We also have items from the Neighborhood Scale, Availability of Healthy Foods, Fruit and Vegetable Community Assessment Tool, Perceived Nutrition Environment, Food Environment Survey. And what is new is the USDA Community Food Assessment Toolkit. It is a food store survey instrument. And just to show you just a little bit about it, this is a standardized and practical set of measurement tools to help assess all of the dimensions that Sarah just talked about at the community level. And this is designed to support a few different folks, community-based organizations, researchers, and local planners as well. And it just helps to paint a broader picture of how systems and infrastructure and local resources interact to support or hinder food access. So SMEs thought this was a good addition. There might be one more community assessment tool that the SMEs are reviewing, and more to come on that.
Just as a reference, my accountable community for health in my health service area performed this survey of our food ecosystem to inform our community health needs assessment, right? So it's actionable. We did it. It informed the assessment, so we were able to understand food access needs in my health service area and have the hospital help intervene on them. Go team. Next slide. Next slide. Data source. Oh, this slide's so cute. So this hasn't changed. The USDA Food Access Atlas determinations of food access are still evergreen in our data sources. Next slide. Again, trying to get through things. Next slide. Nothing new here, right? And just it's a good example. Again, when the measured entity is clear, we are using it. Census tract. That is the data concept for Food Access Research Atlas. When it's not, we're using the neighborhood to represent the place I live, all rolling up to that high concept of physical environment that we know in the Z58 series, right? Next slide. No changes here. Next slide. No changes here. Next slide. Next slide. I love our slides. This is so cute. So the goal concept, and this kind of relates, Mark, to what you were saying in the beginning. We recognize that community food security is different than household food security. I should have and could have put the definition in here. It's been a busy week. It's well defined in the literature what this means. It's a systems level assessment, right? It's about supply, it's about access, it's about affordability, it's about agriculture, right? And so at the highest level, community food security is the appropriate goal for a community level concept of food access. Not attainable really as a goal until everyone is food secure in that household and everybody has good food access. But our goals are aspirational. That's why we make them. And this is the appropriate goal for this domain. Again, definition to come. It's very solid in the lit. We just need to plop it here. Next slide. Next slide. So here's some of that partnership stuff that we were talking about. Again, I think we're doing okay. Yeah, but maybe we'll finish it all. Who knows? Right. So partnerships are a theme across our community domains, right? So if a community is trying to have collective action and it doesn't have enough food, like it doesn't have sufficient food access in its community, new concepts are partnering with food growers to bring, food in, right, to your community. You don't have to wait for the system to send it to you. You can have, collaborations with local farmers to bring food into your area. And we said food growers because we want to be inclusive of produce, dairy, and meats. And so we're using that concept at this time. We did add home delivered grocery programs because we wanted to address the accessibility element within Usher's model. And so we felt like that was important. Community markets are our current term to represent all the ways communities develop retail markets that are not co-ops. We have co-ops, right? But there is like my FQ has a market in order through his federally qualified health center. There's municipal markets. There's, food pharmacies that health systems create. We didn't want to create a market type for each of those. So we're just defining a community market as an intervention. This happens often. We just got the word wrong on for CSA, community supported agriculture programs. And then we're trying to represent the activities when you do incentives to have retail markets come in. This is not through the collective action community market side. It's really when you're trying to bring retail entities like normative groceries into your system. The USDA has its healthy food financing investment initiatives. And we note that there's other kinds of incentives and tax incentives that municipalities can use. So I think actually Lucy, you suggested this. The Retail Healthy Food Market Incentive Program is again, and an example will be the Healthy Food Financing Initiative. All right, and so we do have a set of emergency food sources in our set of information, Denise. More to come there. Owen?
So I don't see in this slide right, but food banks doesn't go right here, right?
Oh, here, just wait. Hold on.
Oh, the next one.
Yeah,
Sorry.
we're coming there. Yeah,
Okay.
emergency food system coming in. Next slide. This is not new. These are all in continuing our work in food programs. These were here 2 weeks ago. Next slide. Right. The whole bulk of concepts from food insecurity that address anything related to food access, including everything in the emergency food system, was dropped in, as we mentioned 2 weeks ago, because in sometimes the first intervention in food access rests upon the emergency food network. And so they're all there, including all the different types of food provision, as a different addition to all the prescribed or medically tailored concepts that are part of the food as medicine approach, dumped in ad hoc by the SMEs to represent food access needs. I hope that answers your, I think that answers your question, Owen and Denise. Next slide. Okay, question. Woo, we did it. Food access in like 10 minutes. Okay, we're trying here. All right, next slide. We're going to try to get through access to green space. Next slide. Next slide. Asha?
Yes. All right. My part again. Okay. So again, here we had a question from MEPS, but it came actually from the Wellbeing and Basic Needs Survey from the Urban Institute. And then we had the Adults, People and Nature Survey for England. We had a set of questions from there because this one really explored blue spaces and wild spaces. And we wanted to include those in our assessments as well. And that is it. We will have some new ones to share with you at our next meeting. That's it for now. If you would like to view that well-being and basic needs, please view it on the Confluence on the master. Thank you.
Look at us go. Next slide. We're doing it. Next slide. No changes here. Next slide. I'm just trying to get it. If I've said it for like 4 meetings in a row, I'm going to move on. This is also unchanged. I want to note, though, the theme, again, of that measured entity, census tracts, census block groups, all different types of geographical spaces, all rolling up to this concept of physical environment, right? All different ways of defining space. We have to honor the data source and the ways defining location and environment, but we want to have a parent concept. Again, this has been around for a while. Next slide. We're trying. We'll see. This is unchanged. Next slide. This slide is also unchanged from 2 weeks ago. Next slide. This slide is also unchanged from 2 weeks ago. Just visibility. You also see it in the master. Next slide. Oh, and a yes.
Something that occurred to me right now, because I was seeing TV the other day and I saw how one of the Asian countries have a lot of indoor places and they have a lot of green indoor. And, you know, we
it's
have
like
winters
that same,
in the north. And so I don't know if we, maybe it's too much to think about that, but indoor places in terms of green. Thank you.
Thank you. It makes me think about the Seattle Convention Center, which feels like a park, but it's inside. Thank you for that. Mark?
And back to the, well, this works fine. I'm thinking about how zip codes are used as a proxy for other things like race. And so, but it's become fairly commonplace and people forget that zip code is not really a suitable geographic measurement. I'm wondering if census tract is a validated, suitable framework for measuring green space, or if we're just sort of resting on it.
It is. It definitely is validated. I encourage you to explore the resources. The fascinating thing is some of them really deep dive into demographic layers and equity layers within the metrics. You know, so please let us know if you feel like that answers the need.
Okay.
Because you can do like in the tree equity score, that literally gives you a breakdown on paths to address equity within that concept. Okay, Owen, hi.
Sorry, this is a
No,
very
sorry.
two-part question. And I like what he said, because when we try to analyze data in my previous job about census tract, we combine in the top the seed code and then all the census tract, because the resources come from cities sometimes are related with seed codes, and not only census tract, and the reality of the implementation and resources is linked with seed code. Even though look, the census tract is very good because you can see all the colors in terms to disparities or difference, and it's in a seed code. So I think the need of both is really important, but to have census tract is important because we know that the geographic area doesn't change with time and everything, right? The data, the particular geographic area is more durable in the census tract than the zip code. So,
Thank
right?
you, Owen.
And try to follow the data for a long time. Yeah.
Yeah, and this is partly why ParkServe and like this, there's also the measurement approach. I mean, a lot of this is measured through the current population survey, and so that is a census level measurement. Patricia, thank you for this reference. We'll look at it. There is one new concept here. We're trying to figure out like simple concepts that represent lots of important things. And so we're using the word fulfilling right now as a goal concept where I want to go, right? Fulfilling meaning providing health benefits. I'm able to use it for physical activity. I'm able to like touch grass and it's biodiverse. Like, so we're just exploring that and not wanting to have lots of concepts to represent all the important things. Does census tract work for green space? Thank you. So we will bring that back to our SMEs there. I don't want to answer that one. Thank you, Mark.
You're welcome. And I understand it takes a little checking. No
We do
worries.
have Indigenous representation beautifully, so we'll make sure that we center them in the answer there.
Thank you.
Okay. Next slide.
Sarah, wait a second. For this slide, able to access personally fulfilling green space. We're at a very macro, I think you're at a very macro level.
Okay.
I'm sorry, very micro level here. Do I have access?
You're talking about this
to-
as a person thing, not a, yeah, I
Yeah,
hear what you're saying.
yes.
I hear what you're saying. It also goes back to what Mark was saying. Does the same concept able to be applied to the person in the community? Thank you. Good note, Lucy, per usual.
So
Oh,
personally
I love
fulfilling.
that. I love that. Thank you. And if we say personally, though, it can't be used at the community level. If we leave it this way, it could be used for both. So we'll bring that back to our SMEs. And thank you, Quandrella. That's lovely. Thank you so much. Great. Love it. Fantastic. Okay, next slide. I think we're not able to get to everything, I think, but we're pretty close. Goals, concepts. Yeah, we're pretty close. Community engagement. Again, we're trying to find one concept that we can have across all of our domains that represent community engagement. We'll get there. Community proud of park spaces. That was something our SMEs thought of. Again, that kind of relates, Lucy, to the community level concept for fulfilling, right? Whoa. Next slide. Wow. Okay, so there's a few new things here. I just want to make sure that we're talking about vacant lot greening because that was really important as an evidence-based intervention here. We just raised community-led initiatives as a goal. We can go back one slide quickly. I know we're at time. We have one. No, actually, no, here we are. So next slide, just to make sure. Next
Sarah,
slide.
is it obvious what vacant lot means? What's a vacant lot?
Oh, it's a what do you mean? What is it's a
I mean, I know what it
urban,
means.
it's an urban setting between existing residential structures that does not have
So
a
that's defined somewhere.
yes.
Okay.
Yeah, and our SMEs were very adamant for this one, specifically in neighborhood safety, even though I don't remember it being in there, because it is so evidence-based and lit for community safety. Like market, like you do this and it
Oh,
helps.
that's wonderful. So you
Yeah.
mean urban vacant lot greening?
Yeah, maybe we need to specify that. Thank you, Lucy.
It
Okay.
would be helpful here. Thank
I
you.
love that. Next slide. I think, I just want to make sure we get to this is just phrasing maintenance. Okay, the only thing I'm gonna say before we go, I know we're at time, is from a point of frugality, we're trying to figure out concepts we can use to talk about maintaining spaces and not have a million of them. We're dividing our approach into flora and facilities, right? There's work to maintain the green part, and there's work to maintain the bathrooms, water faucets, like existing infrastructure. We're figuring it out. I think we're at time. We had a really great meeting today. Classic end-to-end review. Everything is on the master on Tuesday. Please download it. Next week, not 2 weeks, next week. We'll
Sarah,
see you
the
here.
scope of what you and your colleagues have presented today is simply mind-blowing. This is an entire semester of how to think about and address individual, community, political, macro. I mean, it's just mind-blowing what you've just put in
We
an hour and a half, weeks
we
and weeks.
do this. You're part of
Thank
it.
you.
Thank you so much.
Thank you.
We're very, very grateful for all of you. Grateful for our SMEs. Grateful for this collective. Yeah, I was just on a I was on a podcast recently, and someone asked, "What are you most proud of?" I'm like, "I'm proud of us in Gravity, our community. I think it's like really amazing. I'm very grateful for all of you. So go team, and we'll see you. Download the masters on Tuesday. We'll see you in 1 week, not 2. And grateful.
Thank you. Sweet dreams.
Thank you.
Thanks, sweetie.
Thanks,
That's such a nice thing, Mark. Okay. Bye.
Okay.
How about sweet dreaming, Mark? Everything we're doing here is sweet dreaming.
You're right.